Good afternoon, chairpersons and all the esteemed faculty. So I am told that we are running short of time, so I'll start straight away. So after the part of workup, we start with the management part, the cytoreductive surgery in ovarian carcinoma. How much is enough? So starting with the ovarian cancer overview, it is the one of the most lethal gynecological malignancies. So much so that the overall survival of advanced stage of ovarian cancer is less than 20 months. And incidence of ovarian cancer is on the rise, probably due to the decreasing parenting among females. And there is increase in the gynecological conditions like PID and endometriosis. So when we talk about the ovarian cancers, we usually refer to epithelial ovarian cancers, which form the 80% of the all ovarian tumors. The other less common varieties are sex called stromal tumors and germ cell tumors. So coming to the patterns of the ovarian cancer spread, there are four major patterns of ovarian cancer spread. First is the contiguous involvement of the neighboring structures or surrounding organs like uterus, other adnexa, rectum, and bladder. Second pattern is the lymphatic spread, which usually occurs to the subperitoneal route. Then third is the along the flow of ascitic fluid. So it is also known as redistribution phenomena. So what exactly happens is when tumor cells they exfoliate and they flow along the ascitic fluids. So that's why that is the reason that majority of the peritoneal implants in the ovarian cancer they occur in the either in the pelvis, paracolic gutters, or in the subdiaphragmatic peritoneum. So fourth is the hematogenous spread to the distant organs like liver and lungs. So stages of ovarian carcinoma. Ovarian cancer can be divided into early and advanced stages. The early, on the basis of risk categories, is further divided into low risk and high risk. Low risk is stage 1A, grade 1 and 2. And high risk includes all other stage 1 tumors and stage 2 tumors. So advanced stages include stage 3 and stage 4 tumors. So what kind of survival data we are looking at in the ovary? So most important prognostic factor is the stage. So stage-wise, the survival, the 5-year overall survival in stage 1 epithelial ovarian cancers is around 90%. In stage 2, it drops down to 60%. In stage 3 and 4, it further drops to half, that is 30%. So what has happened in last few decades is that 5-year survival, the overall survival and 5-year survival both have increased thanks to the treatment modalities and better surgical techniques. The 5-year survival has increased from 39% to 45%. And the mean survival has increased from 34 months to 52 months. So how the evolution of this cytoreductive surgery took place, so as we know it today. So first description was given by Meigs, and this description was a tumor debulking, and the intent was a palliative one. So to allow for a symptomatic relief and prevention of complications. Then Pemberton, he recognized in 1940 that omentum is a most common site for tumor deposits in ovary. So he proposed omentectomy as a part of cytoreduction. Then, very interestingly, in 1957, the first description of OS, increased OS by the cytoreductive surgery was given. And interesting fact that it was in patients of Burkitt's lymphoma, abdominal Burkitt's lymphoma, in pediatric patients of Africa. Then came this paper, the paper of Griffiths. It's a landmark paper, and this paper established the role of cytoreductive surgery as a mean of increasing the overall survival. And this paper stated that the residual mass was inversely proportional to the overall survival. As the residual lesion decreases, the overall survival increases. So this was the original paper by the Griffiths. And this paper was often, paper is often credited for establishing the role of cytoreduction in ovarian carcinoma. So subsequent to this Griffiths paper, there was abundance of data which had shown that as the size of residual lesion decreases, the survival goes on increasing. So therefore, there was overwhelming support for use of maximal cytoreductive effort. So these trials I have mentioned here, they're Hoskins trial, trial by Chi group and Du Bois group trial. All these have shown that as the residual lesion goes on decreasing, the survival definitely increases. So there is these trials also establish use of maximal or optimal cytoreduction. So look at this trial by Chi group. When there was no gross residual disease, the survival was 106 months. This is equivalent to the 9 years of overall survival. So when the lesion it grows, residual lesion, it is 5 mm. The survival goes to nearly half, about 66 months. Then came this meta-analysis by Bristow group. This meta-analysis was a watershed event. And in the evolution of cytoreductive surgeries, this was a large meta-analysis. 81 cancer cohorts were included, and around 7,000 patients were included in this meta-analysis. And this meta-analysis clearly stated that with the small increase in the residual the effort of the surgeon, there was huge improvement in the overall survival. The 10% increase in tumor resection was associated with 5.5% increase in the median overall survival. So the management of early stage ovarian carcinoma, in early stage, we manage by staging laparotomy with the aim of removing the primary tumor and upstaging the disease. So what are the steps which are included in this staging laparotomy? It is typically preceded by a laparoscopy, evaluation of the peritoneal cavity, then a midline vertical incision is given, followed by the aspiration of ascitic fluid or peritoneal wash, which we sent for cytology. Then thorough examination, very important, to rule out the disease in the upper abdomen. Then THPSO, and intact tumor removal is of utmost importance, so as to not upstage the tumor by causing the surgical spill. So then we typically do infracolic omentectomy as a part of staging laparotomy. Peritoneal biopsy we take from 4 quadrants. Then in the end, it is followed by nodal dissections in the pelvic and retroperitoneal region. So what are the aims of staging laparotomy? First of all, we confirm the histology of the tumor, because most of the cases of ovarian carcinoma, we do not do a preoperative biopsy. Second is to know the accurate extent of the tumor and to guide the further management, whether to give a adjuvant chemotherapy or not. Then third is the comprehensive surgical stage is achieved. Up to 30% chance of their upstaging the disease is there, and therefore it leads to accurate prognostication. Then an advanced stage ovarian carcinoma is managed by cytoreduction. So cytoreduction is done in 3 settings. First is the primary cytoreduction, which is done in upfront setting, interval, which is done after NSCT, and secondary in relapse or recurrent ovarian cases. So what are the rationale? What is the rationale of doing a CRS, or what are the benefits? First are the physiological benefits, which controlling of ascites and elevation of nausea and early satiety by removing the mental cake. Second thing, it increases by removing the bulk of tumor, it increases the tumor perfusion, and it also increases the growth fraction, which in turn increases the sensitivity of chemotherapy. Then third, it negates the development of chemo-resistant clones of the tumor cells. So this model is called as Goldie-Coleman model. So what is the definition of optimal cytoreduction actually? So this definition has evolved over last 4 decades, and the first definition was given by Hoskins group, and they describe it as optimal and suboptimal when tumor was less than 2 cm or greater than 2 cm respectively. What is the GOG definition? It is the optimal cytoreduction is when the residual tumor is less than 1 cm. Then third definition is a CC score definition. So optimal cytoreduction is to achieve a CC score of 0 or 1. That is when there is no gross residual tumor or residual tumor is less than 2.5 mm. So regardless of these definitions, the aim of these oncologists, the gynecological oncologists, should be to achieve a no gross residual disease. So what is the CC score or completeness of cytoreduction score? So it was developed by Dr. Glahan and Gill in early 2000s. And aim of developing this score was to predict the likely benefit from intraperitoneal chemotherapy. So in a study by Veerwal group, the maximum benefit of CRS and HIPEC was achieved when the CC score was 0 or 1. And as the CC score goes on increasing, the benefit of the HIPEC and CRS diminishes. So this completeness of cytoreduction score is also a predictor for overall survival. So what could be the extent of resections in the cytoreductive surgery? These are the procedures which we routinely do in a cytoreduction. But there is really a paucity of data in these regarding the extent of these resections. So what should be the extent of omentectomy? In a macroscopic involvement of the omentum, the total supracolic omentectomy is the standard of care. But when there is no gross involvement of the omentum, what should be the extent of omentectomy? So there is really a paucity of data, though no RCTs are available. there was only a single prospective study by Vidal group, and which showed that there were microscopic deposits in the gastrocolic omentum, even when there was no macroscopic disease. So this study did not report any OS or PFS data. Many institutional reviews, including our own institution, they said that macroscopic deposits over the omentum do a complete supracolic omentectomy. If there were no macroscopic deposits, infracolic omentectomy should suffice. So what should be the extent of peritonectomies? Whether we do an involved field or total parietal peritonectomy, there are two Indian studies in this context. First is the study, a retrospective study by Somsekhar in peritoneal surface malignancies. And in this study, they reported that the overall recurrence rate in the involved field peritonectomy was higher as compared to the 40% in wide field peritonectomy or total parietal peritonectomy. The second study was also an Indian study. It was done by Aditi Bhatt group in the interval developing surgery setting and in stage 3 and 4. And they showed that they reported that platinum resistant recurrence was significantly reduced up to the 7% against an incidence of 11 to 50% in most other studies. So what should be the extent of nodal dissection? So nodal dissection is very important because nodal lymph nodes are often considered as sanctuary sites or harboring disease, and they offer themselves chemo resistance also. So adequate lymphadenectomy up to renal vein should be done. And adequate lymphadenectomy, what benefit does it offer? It upstages the tumor in 20% patients and has a therapeutic value also. So do we really need a lymphadenectomy in patients where nodes are clinical and radiologically inactive? So LION trial is a trial which answers this question. This is a trial in which stage 2B to 4 patients were included, and they were randomized into lymphadenectomy and no lymphadenectomy arm. So these are the LION trial results. The median overall survival was not different in both arms, but the complication rate has increased in the lymphadenectomy arm, 12% versus 6.5%. So very interesting observation in this trial was about 50% of the patients who were clinico-radiologically negative were found to be positive on pathology. So, but still it did not change the overall survival or PFS. So whether to do appendicectomy as a routine part of CRS. So indications of appendicectomy were macroscopic involvement of the appendix or if there are any tumor implants over the appendix. Whether to do appendicectomy in a case of mucinous ovarian neoplasm. So there is no RCT which supports this decision of doing appendicectomy in mucinous ovarian neoplasm, and all the retrospective studies have really conflicting data. So what other organs or structures which can be resected as a part of CRS? So in order to achieve a total no gross residual disease, these all resections can be included as a part of CRS. That is rectosigmoid resections, partial and radical cystectomies, total gastrectomy, splenectomy, colectomies, pancreatectomy, hepatic resections, and full thickness excision of the diaphragm. So when not to operate in a case of advanced CA ovary, or what are the contraindications of cytoreduction? If there are multiple small bowel segments involved, which can risk small bowel syndrome. Second is the involvement of mesenteric root. Then third is the involvement of potahepatic structures. And fourth is diffuse involvement of diaphragm or diaphragmatic muscle. Extra-abdominal disease, which include the presence of inguinal node, supraclavian node, or pleural effusions. Or very important, the poor stage or poor PS or poor nutrition stage of the patient. So what are the predictors of optimal cytoreduction? There are 4 predictors. First is the serum biomarker level. Second is the preoperative imaging. Third is the laparoscopic assessment. Fourth is the PCI or peritoneal carcinomatosis index. So biomarker, which is the most commonly used, is CA125. And the levels which are greater than 500, they predicted a suboptimal resection in majority of the cases. But to be used for CA125 to be used alone as a predictive value, it has a very low predictive value. Second, coming to the role of preoperative imaging. So CT is the most commonly used imaging modality as a predictor for complete cytoreduction. Then most of the models which we use as a predictor are based on CT scan. So we use Nelson model, Bristow model, Dowdy, and Mears model. So Nelson model is described here. So these are all the points and parameters which are described in Nelson criteria. And Nelson in 1993, on the basis of these criteria, he classified patients into cytoreducible and non-cytoreducible. So in patients who were labeled as cytoreducible achieved cytoreduction in 23% of the patients. But patients who were labeled as non-cytoreducible, only 16 of the 18 patients were able to achieve optimal cytoreduction. So third is the laparoscopic based assessment. This was done by Anna Fagotti group, and they developed a Fagotti score on the basis of all the parameters. The predictive index value they introduced by summation of all the parameters. So importance of predictive index value, when it is greater than 8, there was high chances that suboptimal resection will be achieved. So these are all the features which are included in the Fagotti score, and all these parameters are assessed on the laparoscopy. So fourth predictor is the peritoneal carcinomatosis index, and this was developed by Sugarbaker in 1990s. And this combines the lesion size with the disease in the peritoneal location of the disease in the peritoneal cavity. And the score of the PCI, it ranges from 1 to 39. There is no value which limits the process of cytoreduction in the ovary, but in colorectal cancers and in stomach cancers, there is a value for limiting the optimal cytoreduction. For CRC, colorectal cancer, it is less than 20, and for stomach, it is less than 12. So this is the abdomen is divided into 13 regions and also includes the lesion size. So coming to the long pending debate of primary versus interval cytoreduction. So prior to 2010, what happened was there was all data which was retrospective, and it was somewhat favoring NSCT over the primary cytoreduction. After 2010, 4 RCTs were published: ERTC, CHORUS, GSCOG, and Scorpion trial. So these are the patient characteristics which are well matched in both trials, both groups in all the trials. These are the inclusion criteria and design of the trials. First 3 trials, ERTC, CHORUS, and GCOG, were non-inferiority trials. Scorpion was a superiority trial. So what was the results of the ERTC trial? The overall survival was similar in both groups, but the NSCT followed by interval developing surgery was associated with lower post-operative complications than the primary cytoreduction arm. So one of the major criticism of this study was that only in 41.6% of the patient in the primary cytoreduction arm had a complete optimal cytoreduction, as opposed to 80% in the NSCT group. Then CHORUS results, these are also similar to the EORTC results. Median overall survival was both same in these 2 groups. Again, the same criticism which was of EORTC trial. The optimal cytoreduction was only achieved in 41% of the primary cytoreduction arm. So this was the JCOG trial. The results were similar to the previous 2 trials. Then came this trial of Scorpion trial. It was the first trial which used laparoscopy prior to the performance of cytoreduction. And the primary outcomes which were included in this trial were the superiority, to establish the superiority of NSCT over primary CRS. But there was no difference in the PFS between 2 groups, and NSCT followed by interval debulking surgery had a significantly lower post-operative complication. However, the superiority of NSCT over primary cytoreduction could not be established in this trial. So what were the conclusions drawn from these 4 trials? The performance of CRS as early as possible in the course of disease should be a standard rather than a interval cytoreduction. Interval cytoreduction you reserve for patients with a poor PS, poor nutritional state, and very high disease burden. So what is the secondary CRS? It is the performance of cytoreduction in the recurrent or relapse setting. Most appropriate patients were platinum sensitive and limited value disease. So question here is, where does this secondary cytoreduction stands in the era of bevacizumab and PARP inhibitors? So there were 3 RCTs. First was GOG 213 trial, second was the SOC1 trial, and third was the Izastop 3 trial. So GOG 213, it was a multicentric trial which was comparing CRS and chemotherapy, and bevacizumab and PARP inhibitors were allowed in this trial. So the patient population there was no specific selection criteria, except that patient should be platinum sensitive and a potential surgical candidate. Only 67% of the patient had a complete or optimal cytoreduction, and there was no difference in the overall survival or PFS. So second trial was a SOC1 trial. It was a Chinese multicentric trial. So one of the advantages of the trial is that the well-defined selection criteria was there. That is a Tian score. It was very similar to the criteria which was used in the Desktop 3 trial, that is AGO score. There was significant results of the trial showed that there was significant difference in the groups, and the OS favored the secondary cytoreduction over chemotherapy. So better overall survival also seen in the interim analysis of this trial. So when we compared the subgroup analysis, incomplete cytoreduction and chemotherapy had similar PFS. So coming to the last trial of the secondary cytoreduction, desktop 3 trial, it was an international multicentric trial, and patients were very well defined. Patient population very well defined. First platinum sensitive relapse or positive agar score, and complete CRS was achieved in 76% of the patients. After a follow-up of 69 months, OS was significantly better in the CRS compared to the chemotherapy arm, and PFS was also better in this secondary cytoreduction arm. So this is the agar score. So I will skip this. So what were the conclusion which could be drawn from these secondary cytoreduction arms? 2 out of 3 trials have reported survival improvements for secondary cytoreduction versus chemotherapy arm. Survival was only possible when complete microscopy, the optimal cytoreduction was achieved. And patient selection criteria were very important with the help of TIAN score and agar score. And both trials, which have achieved a positive outcome for CRS, had allowed bevacizumab and PARP inhibitors also. So in spite of including bevacizumab and PARP inhibitors, the surgery arm showed a better overall survival and PFS. So coming to the concluding remarks, ovarian cancer is one of the most legal gynecological malignancies. The maximal cytoreduction of the optimal cytoreduction offers maximum survival benefit, and surgery to be preferably undertaken in the centers where there is high volume, high disease load. Primary CRS should be preferred over interval cytoreduction except for few selected patients. And secondary CRS have a survival benefit, has a definitely a survival benefit in patients who are well selected, as in the desktop criteria, that is the AGO OVAR score was there. So that's all. Thank you very much.